Now we are going to start kidney and ureter. And in kidney and ureter, we are going to start first the renal stones. Okay. So for renal stones, there are two mandatory factors. So what are those two mandatory factors for formation of renal stones? One is supersaturation and second is crystallization. Okay. So see, for renal stones, what are the mandatory factors? One is supersaturation, right? And the second is crystallization. Simple. After that, there are Rendal plaques, and these Rendal plaques acts as a nucleating agent. What are these Rendal plaques? These are the soft tissue calcification, and these are located in deep renal medulla. Okay, so see, what are the Rendal plaques? Rendal plaques. Okay, so these are going to act as a nucleating agent for renal stones, right? And what is the location? These are soft tissue calcification, soft tissue calcification, and these are located in deep renal medulla, deep renal medulla, right? And these acts as nucleating agent for renal stones. Clear? Now one by one we are going to discuss the renal stones. First question, that what is the most common type of renal stone? This is calcium oxalate. Clear? Second, this calcium oxalate stone is radio opaque or radiolucent. So it's very easy to understand. See, if there is oxalate, carbonate, bicarbonate, salt with calcium, all these are generally radio opaque. So calcium oxalate is radio opaque. Second, risk factors are asked. So no need to remember risk factors. It's very easy to understand. Suppose the name of stone is calcium oxalate, it means what is the composition? It's the calcium and oxalate, and calcium and oxalate should combine together. It means there should be increased concentration of calcium as well as oxalate in the urine. So what will be the risk factors? First, calcium increased concentration in the urine means hypercalciuria, oxalate means hyperoxaluria, and in which case you will find hypercalciuria, hypercalcemia. So what are the risk factors? Hypercalcemia, hypercalciuria, hyperoxaluria. Clear? So one by one we are going to discuss the renal stones. First, most common type renal stone, this is calcium oxalate. So this is most common type. This is radio opaque. And what are the risk factors we discussed? Risk factors, first, hypercalcemia. It's hypercalcemia. Second is hypercalciuria, hypercalciuria, and hyperoxaluria, hyperoxaluria. Simple. Okay. Second, what is the most common radiolucent renal stone? And that is uric acid stone, right? So uric acid stone is the most common radiolucent renal stone. Okay, and for formation of uric acid stone, obviously there should be increased concentration of uric acid in the urine. It means the person must be having what? Hyperuricemia. So increased concentration of uric acid in the blood and urine increases the risk. So hyperuricemia is a risk factor. It means indirectly what are the risk factors for uric acid stone? Yes, gout, Lesch-Nyhan syndrome, and myeloproliferative disorders in which we give chemotherapy. There is increased breakdown of cells and increased production of what? Uric acid, right? So second is uric acid stone. Okay, so first important point, this is the most common radiolucent renal stone. Okay, and it is seen in the patients who are having hyperuricemia. Simple. So what are the risk factors? So obviously the risk factors, first is the gout, Lesch-Nyhan syndrome. In Lesch-Nyhan syndrome, there is self-mutilating behavior, there is hyperuricemia, myeloproliferative disorder, clear, in which there is increased breakdown of cells, and because of that sometimes there is what, tumor lysis syndrome. Okay, now what is the problem in this uric acid stone? See how this uric acid is formed. Initially there is hypoxanthine. This hypoxanthine is converted into xanthine, right? And this xanthine is converted into uric acid. Simple. You must be knowing that there is a drug which is going to block both of these steps. And what is the name of that drug? The name of that drug is what? Allopurinol. Clear? So it is the allopurinol. Okay, so now you understood that we can use allopurinol in this particular stone. Now see, there are 2-3 basic principles which we are going to follow in the management of renal stones. One, we discussed that 2 mandatory factors are what? Supersaturation and crystallization. Okay, so if you can prevent the supersaturation of crystal, you can prevent the stone formation. How you can prevent the supersaturation? If you can dilute the urine. And how you can dilute the urine? By excessive fluid intake. So if patient is taking plenty of fluids, what happens? You can prevent the stone formation. One principle. Second, acidic stone precipitates in acidic urine, and alkaline or basic stone precipitates in basic urine. So if you know the nature of stone, suppose uric acid stone is there, so the name is self-explanatory, uric acid. So this is acidic stone. So what we can do, we can perform the alkalinization of urine. So what happens? Acid combines with alkali and forms the salt, and salt is soluble, and this soluble salt can be easily excreted in the urine. So what are the management principles which we are going to follow here? First, plenty of fluids. Basic principles, plenty of fluids. Second, alkalinization, because the stone is acidic, and we can give acetazolamide for alkalinization. Okay. Third principle, we should decrease the production of uric acid. So what should be taken in lesser quantity? Low purine diet. So what? We should take low purine diet. Okay, and despite of these, if we have to start a drug, we can easily use which one? Allopurinol. Clear? So this is how we are going to manage the uric acid stones. Now see this image of stone and see this X-ray and identify what is the type of stone. So if you see the shape of the stone, can you see? This is the shape of stone. Clear? And it looks like what? Stag horn, because there is branching in the stone. You can see here also in this X-ray. So you can see what? That there is branching in the stone, and this is known as what? It looks like horn of stag. So this is staghorn stone. What are the other names of staghorn stone? It is also known as struite stone, also known as triple phosphate stone. Clear? So this is struite stone. The other names of struite stones, this is staghorn calculi. It is also known as triple phosphate stone. Clear? And what is the composition of triple phosphate? The composition is, it's calcium, magnesium, ammonium phosphate. Calcium, magnesium, ammonium phosphate. See, this struite stone is more commonly seen in females. So it is more common in females. Why it is more common in females? In females, the length of urethra is 4 cm. So females have shorter urethra, and because of this shorter urethra, there is increased risk of UTI, urinary tract infection. And because of this increased risk of UTI, especially by which organism? Proteus. What happens? This proteus is going to produce one enzyme, urease, and this urease is going to convert urea into ammonia. So what happens? This proteus it produces urease, and this urease, it converts what? Urea into ammonia. Clear? And here you can see this ammonia is precipitated here with calcium, magnesium and phosphate. So there is formation of what? Struite stone or staghorn calculi. Right? Now see the simple anatomy. Here you can see that this is kidney. These are the minor calyces. How many minor calyces are there? There are 3 to 5 minor calyces. These 3 to 5 minor calyces are going to join together and form major calyx. Okay, so this is what? Major calyx. After that, there is pelvis, there is ureter, so there is pelvi-ureteric junction. Struite stones are very large, right? And these are so large that these are going to fill this pelvic calyceal system. So these stones are so large that these are going to fill the pelvic calyceal system, right? Second thing, there is no severe pain. So pain is generally either pain is not there or very little pain is there. So what happens? Because large stone is there, so it causes silent destruction of kidney. And if it is bilateral, what happens? Sometimes patient might present with bilateral hydronephrosis leading to renal failure. Clear? So these stones are very large. These are very large, fills pelvic calyceal system, and it causes silent destruction of kidney. Silent destruction of kidney. And since the stones are having what? Branching, so it is known as staghorn calculi. Now see, the stones are so large that a single technique of stone removal is generally not sufficient. So we are going to combine two techniques together for removal of the stone. One, we are using PCNL. What is the full form? Percutaneous nephrolithotomy. And we are using ESWL. What is the full form? Extracorporeal shockwave lithotripsy. Since we are using both of these techniques together, this is known as what? Sandwich technique. So how we remove these stones? By sandwich technique. So how we are going to treat these stones? We are going to use sandwich technique. Clear? And in this sandwich technique, what we are going to use? PCNL plus ESWL. Next is cystine stone. Cystine stone. Cystine stone is seen in cystinuria. What is cystinuria? It's a metabolic disorder. So cystinuria means there is increased concentration of cystine in the urine. So it is seen in cystinuria. Okay. Just now we discussed that whenever there is a stone containing calcium phosphate, carbonate, bicarbonate, oxalate, these are radio-opaque stones. Here in cystine, it's not a salt of calcium, there is no phosphate carbonate. Despite of that, it is radio-opaque. Why it is radio-opaque? Because in cystine stone, there is double sulfur bond or disulfide bond. So because of this disulfide or double sulfur bond, what? It is radio-opaque. This is radio-opaque. Okay. Cystine stones are very hard. These are so hard that these are not easily broken by ESWL. So these are very hard stones. Very hard. These are not easily broken on ESWL. And if you see the shape of crystal, this is the shape of crystal. You remember this structure? We used to make this structure in class 11th and 12th. This is benzene. So this is the benzene shaped, or this is hexagonal. So the shape of crystal is, it's hexagonal or benzene shaped. Clear? Now we read that generally in metabolic disorders we are using complexing agents. You must be knowing Wilson's disease, in which we are using complexing agent for copper, that is D-penicillamine. So here for cystine also we are using complexing agent D-penicillamine. There is another alternative, alpha mercaptopropionil glycine. Right? What is the problem with D-penicillamine? That patient are not going to tolerate this particular drug, D-penicillamine. So the better drug is what? Alpha mercaptopropionil glycine, right? So how we are going to manage this cysteine stone we give complexing agent. What we are giving? Complexing agent. Okay, there are options. We give D-penicillamine. This was asked many times in exam. And what is better than D-penicillamine? It's alpha mercaptopropionil glycine, because this is better tolerated. It's better tolerated by patients. So this is how we manage cysteine stones. Then there is xanthine stones. Okay, so obviously this xanthine stones are seen in which condition? In the urine there should be increased concentration of xanthine, so these are seen in xanthinuria, and these xanthine stones are radiolucent, so this is seen in xanthinuria, and the stones are radiolucent. These are radiolucent stone. Now see, if you are looking at the stone, just by looking at the stone you can identify that yes, this is xanthine stone. How? By the color. And if you are going to take the cut section of the stone, what you can see that there is lamination on cross section. So what is the color of this stone? So see the typical color, it is brick red. So the typical color, can you see? This is brick red. Clear? And this was asked in NEET PG. So what is the color? Brick red, and it shows lamination on cross section. Clear? So it's brick red in color and it shows lamination on cross section. So that's why you can identify this stone just by looking at the stone. Now we discuss this cycle that hypoxanthine is converted into xanthine, and then xanthine is converted into uric acid. Simple. And there was one drug which was blocking both of the steps. So obviously which drug you can use in this stone also? We can use allopurinol. So in this stone also you can use what? Allopurinol. Nowadays in exams, drug induced stones are also asked. Like suppose somebody is taking triamterene. Triamterene is potassium sparing diuretic, and because of excessive intake of triamterene there is formation of radiolucent stone. Suppose HIV positive patient is there and he is taking what? Protease inhibitor. Which one? Indinavir. And because of excessive intake of indinavir also there is formation of what? Radiolucent stone. Somebody in our family who is having gastritis frequently, and you have seen that that person is taking antacids on frequent basis or on daily basis. So if that person is having some evidence of gastritis or some symptom of gastritis, person is going to take antacid. Some antacids are containing silica. So excessive intake of silica containing antacids leads to silicate stones, right? So what are the drug induced stones? See, triamterene stone. Triamterene. This is potassium sparing diuretic and it leads to formation of radiolucent stone. Clear? Second is indinavir. Indinavir is protease inhibitor, and excessive intake of this drug also leads to radiolucent stone. And the third is silicate stone. Silicate stone. So some antacids contains silica. So this is because of excessive intake of silica containing antacids. Simple. After that, indirect questions are asked that out of these stones, how many are radiolucent, which one are radio-opaque? So see, what are the radiolucent renal stones? Radiolucent renal stones. So there is a mnemonic to remember, and the mnemonic is TICSU. TICSU is radiolucent. So what is the full form? Clear? So T means triamterene. This is triamterene. I means indinavir, which we discussed here. Indinavir. Clear? X means xanthine. And U means uric acid. Okay, one question. Second, which stones are acidic? How to remember? The mnemonic is CCU is acidic. So what are the acidic stones? And the mnemonic is CCU. CCU is acidic. So C, calcium oxalate, C, cysteine, and U, uric acid. Clear? So these are acidic stones. Okay. After that, questions are asked that renal stones are more common in males or females. Now see, you have to read the question carefully. Renal stones are more common in males, but infectious renal stones are more common in females. Okay. So renal stones are more common in males. Okay. But infectious renal stones, because females have increased risk of UTI, these are more common in females. Okay. Now what is the symptom? You have seen that some of your friend, some of your relative, or sometimes even yourself, you have stone. And if you have renal stone or some of your relatives having renal stone, ask what's the problem. The patients are going to complain that they have pain on regular basis. So what happens? There is abdominal pain, and that's the most common presentation. Now what is the problem? Sometimes this stone is going to obstruct the renal pelvis. Okay, and whenever there is obstruction caused by the stone in the renal pelvis, there is stretching of renal capsule, and whenever there is stretching of this renal capsule, this leads to non-colicky pain. Okay, sometimes the stone fragments are coming into the ureter, and you know ureter is a peristaltic organ. So whenever that stone fragment comes into the ureter starts doing hyperperistalsis, and because of this hyperperistalsis, what's the problem? There is colicky pain. So because of stretching of renal capsule, there is non-colicky pain, and because of hyperperistalsis of ureter, there is colicky pain. 2 points. Third, the location of stone is going to decide the radiation of pain. So the radiation where the pain is going to radiate, it depends on the location. Okay, so see the clinical features. First, what's the most common symptom? Most common symptom of renal stones, and that's abdominal pain. It can be colicky, non-colicky, and radiation depends on the location. So see where the pain is going to radiate. This is kidney. Okay, this is pelvis, and this is the ureter. This is the bladder. Now this is upper 1/3, this is middle 1/3, this is lower 1/3. So whenever the stone is in the renal pelvis or in the upper 1/3 of ureter, here pain radiates to testes in males and labia majora in females. Simple. Now whenever the stone is in the middle 1/3 of ureter, when the stone is in the middle 1/3 of ureter, the stone radiates to iliac fossa, groin, and hypogastrium. So here pain radiates to iliac fossa, hypogastrium, and groin. Clear? Iliac fossa, hypogastrium, groin. So question, via which nerve? So you can see here, and you can easily remember iliac fossa, hypogastrium. So what's the name of nerve? Via iliohypogastric. So via which nerve? Via iliohypogastric. Simple. Now see, suppose the stone is in the middle 1/3 on the right side of ureter. So in right ureter, in middle 1/3 stone is there. So pain is going to radiate to right iliac fossa, and that's why it mimics which condition? Pain radiates to right iliac fossa, so it mimics acute appendicitis. And suppose stone is in the middle 1/3 of left ureter, so pain radiates to left iliac fossa and it mimics which condition? Diverticulitis. Clear? So here on right side, this condition mimics acute appendicitis. It mimics acute appendicitis, and on left side it mimics diverticulitis. Simple. Now when the stone is in the lower 1/3 of ureter, if it's in lower 1/3 of ureter, the pain radiates to inner aspect of thigh, scrotum and perineum. So here pain radiates to inner aspect of thigh, scrotum and perineum. Clear? And this question was also asked in DNB and NEET via which nerve, and this occurs via ilioinguinal nerve. This was asked in All India also. So via ilioinguinal nerve. Now sometimes the stone is stuck here, where? In the intramural ureter. And when the stone is stuck in the intramural ureter, patient is having strangury. Okay, so see, if the stone is stuck in intramural ureter, here the patient is having strangury. So what is strangury? It's a painful frequent urination of small volume. And what is the problem in strangury? Painful frequent urination of small volume. Patient has to strain too much to expel the urine. So that's strangury. So these are the clinical features. Okay. Whenever we suspect the renal stone, what is the investigation of choice for the diagnosis? It is non-contrast spiral CT. This was asked many times. So diagnosis, investigation of choice for diagnosis, and that's non-contrast spiral CT. This was asked many times in the exam, right? Whenever these patients are coming to our emergency, what we give? Analgesic. And what is the drug of choice? It is Voveron. That's the brand name. So diclofenac sodium or Voveron. So how we are going to manage the pain? Yes, drug of choice is diclofenac Now see, whenever these patients are coming to our emergency, we give analgesic, that's diclofenac. Sometimes we give antispasmodic also. Whenever pain is relieved, we discharge the patient, right? And we call this patient in OPD. So whenever the patients are coming to OPD, we start the investigations. So what are the investigations which are done in these patients? This investigation begins from the urine. Okay. So in urine, which investigation? First, urine RM. So what are the investigations which are done? First, urine, routine microscopic examination, urine RM. And see, when you people submitted your medical, sometimes in our medical we had to submit the urine RM report. So if you have seen your urine RM report, what is mentioned? First, color, pH, specific gravity, color, pH, specific gravity, presence of sugar, albumin, RBCs, WBCs, pus cells, cast and crystals. Clear? So basic information will be there from this urine RM report, and you will be having rough idea whether this patient is having UTI or not. Rough idea means indirect evidence. And what's that indirect evidence? If there is presence of WBCs or pus cells. Indirect evidence. Second, you will be having indirect evidence of stone also. How? By presence of crystal. So crystals will be there, and by presence of crystals you can predict that what kind of stone patient is having. See, these two things are frequently asked in exams nowadays, cast and crystals, and these questions are asked in the form of image based questions. So you must be knowing all the cast, their images and crystals. Okay, so now we are going to discuss the images of crystals one by one. So now you can see what is the shape. It is just like dumbbell. Okay, so this is dumbbell shaped crystal, and this dumbbell shaped crystal is seen in calcium oxalate monohydrate. You have to remember calcium oxalate what? Monohydrate. So in calcium oxalate monohydrate, clear, there is dumbbell shaped crystals. What happens in calcium oxalate dihydrate, or sometimes only the term is mentioned in the question is calcium oxalate. If only calcium oxalate is mentioned, you have to assume that it is calcium oxalate dihydrate, and in that bipyramidal or envelope shaped crystals are seen. So here you can see this is calcium oxalate dihydrate crystal, and you can see that this is what? Bipyramidal or envelope shaped. Clear? This was asked in AIMS also. Now see here, rosette shaped multifaceted crystals. So these are rosette shaped multifaceted crystals, and these are seen in which stone? Uric acid stone. So these are seen in uric acid stone. So these are uric acid crystals. These are multifaceted and rosette shaped. Here you can see that this is amorphous crystal, and this amorphous crystal is seen in calcium phosphate. So it is seen in calcium phosphate. So in calcium phosphate, amorphous crystals are seen like this. So this is what? Amorphous crystal. This was asked many times. Can you see the shape? See the shape? So it is coffin lid. So what? Coffin lid. Coffin lid crystals are seen in struwite stone or staghorn calculi, right? So this is struwite stone crystal, and in struwite stone, what kind of crystal? Coffin lid. Okay, coffin lid crystals are seen. Here you can see needle shaped crystals. So can you see needle shaped crystals? And these are seen in brushite stone. Okay, so brushite. So in brushite stones, we find needle shaped crystals. Clear? And in cystine stones, we discussed hexagonal or benzene shaped crystals are seen. So here you can see benzene shaped or hexagonal crystals, and these are seen in cystine stones. So in cystine stones, we find hexagonal or benzene shaped crystals, right? So all these are very, very important, frequently asked in exams. After that, there are three important questions which are asked. First, how many renal stones or what percentage of renal stones are radio-opaque? So 90%. 90% renal stones are radio-opaque. 80% of salivary gland stones are radio-opaque, and 90% of gallstones are radiolucent. Okay, so 90% of renal stones are radio-opaque, 80% of salivary gland stones are radio-opaque, 90% of gallstones are radiolucent. It means if 90% of renal stones are radio-opaque, you can detect these renal stones by X-ray. So you can detect these by X-ray. So which investigation is done? Radiological investigations. We can go for X-ray KUB. KUB means kidney, ureter, bladder. Why? Because 90% renal stones are radio-opaque. Radio-opaque. So you can detect the stones on X-ray KUB, but what is the problem? This X-ray will not give you any idea about exact site of obstruction, about hydronephrosis, about renal function, right? So this will not give you the idea of hydronephrosis. So you want to know whether there is hydronephrosis or not. So what is the screening investigation for hydronephrosis? And that's ultrasound. So we go for ultrasound. It's the screening investigation for hydronephrosis. But from ultrasound, hydronephrosis can be detected, but exact site of obstruction cannot be detected. And what? Renal function. So renal function and exact site of obstruction cannot be detected by ultrasound. So there is an investigation known as IVP or IVU. What is the full form of IVP? This is known as intravenous pyelogram, also known as intravenous urogram. How we do this intravenous pyelogram or intravenous urogram? So name is intravenous. So you inject the dye IV, and after injecting the dye IV, this dye is being taken by kidney, and kidney is going to concentrate the dye, excrete the dye in urine. So what we are going to take serial X-rays after giving the injection of dye. What happens? Initially you can visualize the kidney. After that you are going to notice that slowly this contrast start going into ureter, and then you can visualize the whole ureter, and in the last film you can see that dye is collected where? In the bladder. This is the normal sequence. Now imagine a situation in which patient is having the stone, and on one side you can visualize the whole ureter on one side, and on other side you can see only this part of ureter. So on one side the complete ureter is visualized, but on contralateral side only this part of ureter. It means what is the problem? There is obstruction. So what is the advantage of IVP? You can detect the site of obstruction. Simultaneously, renal function. So apart from hydronephrosis, site of obstruction, renal function can be assessed. But what is the problem? Yes, if there is obstruction, you can assess only proximal part of obstruction. You can assess this proximal part of obstruction. You have no idea that what's happening here, where in the distal part of obstruction. So by IVP we are going to assess the proximal part of obstruction, and this question was asked in comment K, that if we want to assess this distal part of obstruction, which investigation should be done? So we have to inject the dye from below. So we have to go into urethra, then bladder, then cannulate the ureter and inject the dye from below. See, if something is going to follow the flow, means if something is along the flow, that's known as antegrade, and if something is against the flow, that's known as retrograde. So which investigation is done here? When the dye is injected against the flow, this is known as RGP, what? Retrograde pyelogram, and here it's IVP. So to assess proximal part of obstruction, what is done? IVP. To assess distal part of obstruction, what is done? RGP. Okay, so this IVP, it is for site of obstruction. This is for assessment of hydronephrosis and renal function, and it is going to assess which part of obstruction? Proximal. Which one? Proximal part. And for distal part we go for RGP, retrograde pyelogram. So this is going to assess the distal part of obstruction. Okay, now lots of questions are asked nowadays related to radionuclide scans. Okay, and the radionuclide scans are also used in renal stones, in kidney. So what are the radionuclide stones which are used? One is DTPA scan, one is DMSA scan, one is MAG3. So one by one we are going to discuss. First, DMSA scan. So it's DMSA. What is the full form of DMSA scan? This is dimercaptosuccinic acid scan. Dimercaptosuccinic acid scan. How to remember? You can easily remember. It is used for M. M means morphology, S means scar, and SA means surface anatomy. Surface anatomy. Clear? So this DMSA scan is used for renal morphology, renal scar, surface anatomy. So the condition in which there is formation of renal scar, DMSA scan is investigation of choice. You tell me what's the name of that condition? Common in children who are having VUR, vesico-ureteric reflex. chronic pyelonephritis. So in chronic pyelonephritis, what happens? In chronic pyelonephritis, there is presence of scar. So what is the investigation of choice in chronic pyelonephritis? DMSA scan. Clear? Next is DTPA scan. DTPA scan. What is the full form of DTPA? Diethylene triamine pentaacetic acid scan. Diethylene triamine pentaacetic acid scan. How to remember? Here see, this is P, and P means perfusion and function. So this means perfusion and function. Okay. So DTPA scan is investigation of choice for renal perfusion and renal function. It's investigation of choice for renal perfusion and renal function. Third is MAG3. MAG3. Now what is the full form of MAG3? Mercaptoacetylglycine. So this is mercaptoacetylglycine. How to remember? See, G. And G means gold standard for renal function. So G means this is gold standard for renal function. Investigation of choice for diagnosis for renal function is DTPA scan, but the gold standard investigation is what? MAG3, mercaptoacetylglycine. So these are the battery of investigations which are done in patients who are having renal stones. Clear? So after investigations, you can easily decide that in which cases you are going for conservative management and in which cases some kind of intervention is required. See, sometimes our relatives are going to call us after getting their report of ultrasound or IVP that, look, I'm having the stone in kidney of this size. What should I go for? Because my surgeon is advising me to go for the surgery. So in which cases conservative management is sufficient? So see, what are the indications of conservative management? Okay, the most important thing is what? Size of stone. So size up to 5 mm. Up to 5 mm. Okay, there should be non-dilated ureter. If the stone is located in lower third of ureter, stone in lower third of ureter, and there is progressive downward movement on repeated scan, means slowly the stone is moving downwards in the ureter. So there is progressive downward movement on repeated scan. Progressive downward movement on repeated scan. Clear? And what we advise in conservative management? Nothing. We advise the patient that take plenty of fluids. The moment we are going to tell the patient that you are having stone, but the size is up to 5 mm, so you can take plenty of fluids, and generally what will happen? The stone will be excreted in urine and its size will become smaller. So no need to go for any kind of surgical intervention. The moment we are going to ask the patient to take plenty of fluids, immediately the patient is going to ask us that, sir, can I take beer or alcohol? Because my friend was suggesting that take beer and stones will be excreted in urine. So strictly you are not going to advise beer. What is better than beer? Yes, water. So how much? It is said that for a 4 mm stone, take 4 liters of water for 4 weeks, stone will be excreted in urine. But this is applicable only for 4 mm of stone. Got it? So generally how much liquid is advised? At least 4 to 6 liters per day. So in this conservative management, what we are going to advise? Plenty of fluids. Generally 4 to 6 liters per day, and alkalinization. Or suppose the stone is acidic. Most of the stones are acidic, so we go for alkalinization. We advise the patient that get Alka-Sol alkaline solution. Or if the stone is basic, then we go for acidification of urine. Clear? But suppose this criteria is not fulfilled. If the size of stone is bigger or patients are having certain complications, in those cases we have to go for what? Surgical interventions. So what are the surgical interventions done? So the surgical interventions. So what are the options for renal stones? First, we have ESWL, we have PCNL, we have URS, we have LSS, and we have OSS. Okay, what is the full form? ESWL means extracorporeal shock wave lithotripsy. PCNL means percutaneous nephrolithotomy. URS means ureteroscopy. LSS means laparoscopic stone surgery, and OSS means this is open stone surgery. Clear? Now see, this ESWL, this is curative for 85% of stones. Can you see the picture? 85%. And if you see this PCNL and URS, this is curative for 15% of stones. So if you add, it's almost 100%. So since ESWL, PCNL and URS, these are curative for most of the stones, what? There is no significant role of these two interventions, and generally these are not done. I said generally these are not done. There are only two indications of open stone surgery, in which case you perform open stone surgery. Imagine if a patient is having stone and patient is having non-functioning kidney. What is the definition of non-functioning kidney? On DTPA scan, if the function is less than 10%, in that case we have to perform nephrectomy, and for nephrectomy obviously we have to go for the open approach. Second, if a patient, means a child, having congenital abnormality with stone, means if a child is having PUJ obstruction with stone and we have to perform pyeloplasties, generally open approach is preferred. So this open stone surgery, yes, this is done in which case? First, stone with non-functioning kidney, we have to perform nephrectomy, and second, stone with congenital abnormality of kidney like PUJ obstruction. Clear? So in these cases only we go for what? Open stone surgery. Now we are going to discuss ESWL. ESWL, the full form is extracorporeal shockwave lithotripsy. So the name is extracorporeal. It means the shock waves are generated outside the body, and after that these shock waves are focused inside the body. Okay, whenever these shock waves are focused inside the body, what happens? See, this is the kidney and this is the ureter, and in the kidney there is a stone. So whenever these shock waves are focused on the kidney, what happens? There is a change of density from soft to hard. Why? Kidney is a soft tissue and the stone is hard. So whenever there is change of density, what happens? The energy is released over the surface of stone, and when energy is released over the surface of stone, what will happen? The stone cracks. This is known as shock wave induced tensile cracking, and after that what? The stones are broken into small pieces. So this is known as erosion and shattering, and after that what you can see that these are the stone fragments, and these stone fragments are excreted into urine via ureter, right? So in this case we are using a gold standard lithotripter. So what is the name of that gold standard lithotripter? It's Darnier unmodified HM3. Okay, so the name of this gold standard lithotripter, it's Darnier unmodified HM3. Clear? After that, the shock waves are focused onto the kidney, and when there is change of density from soft to hard, the stones, these are the stones, these are broken into small pieces, and these pieces are excreted into urine via ureter. Right? Now, what is the prerequisite for this? That ureter should be patent. Okay? If there is obstruction in the ureter, what's the problem? Yes. Suppose The obstruction was not ruled out preoperatively. So what's the problem? If there is some obstruction into the ureter, what will happen? The stone fragments will be collected into the ureter proximal to obstruction. Clear? And this complication is known as Steenstrasse, also known as street of stone, also known as columnation of gravel. Clear? So whenever there is obstruction into the ureter, there is Steenstrasse, means stone fragments will be collected into proximal part of ureter, also known as street of stone, also known as columnation of gravel, columnation of gravel. Clear? So ESWL is very effective treatment option for renal stones, and any kind of renal stone can be removed, but what you have to remember, the size. So what is the maximum size which can be removed by ESWL? It's 2 cm. See, two questions are asked. What is the maximum size of CVD stone which can be removed by ERCP? That is 1.5 cm. And the maximum size of renal stone removed by ESWL is 2 cm. So you have to remember a question related to ERCP. Maximum size of ERCP stone removed by ERCP 1.5, and renal stone by ESWL maximum size of stone removed is 2 cm. Okay, so one, the size which can be removed is 2 cm. Second, the stone should not be very hard. We discussed that cystine stones are very hard, not easily broken by ESWL. Apart from cystine stone, there are 3 other stones which are very hard, not easily broken by ESWL. Clear? So question, what are the hard stones? Hard stones not easily broken by ESWL. So first, bruchite. Second is hydroxyapatite. And third, cystine. And the fourth is calcium oxalate monohydrate. Calcium oxalate monohydrate. Right? All these questions were asked in exam. So how to remember? The mnemonic is BHC2. So you can easily remember BHC1C2. So the mnemonic is BHC2. Right? So any stone can be removed by ESWL. These are the exceptions. The size should be within 2 cm and this should not be very hard. Right? Now the problem. You know that in ESWL shock wave is given to the body. Now the problem. If patient is pregnant, in those cases you cannot give shock waves to the body or to abdomen. Why? Because these can cause injury to the fetus. One problem. Second, because of the shock waves, what happens? Sometimes there is risk of hematoma to the kidney. So there is renal hematoma. And the patient who is already having some kind of bleeding disorder, in that case there is high incidence of renal hematoma. So these are 2 absolute contraindications. So what are the contraindications of ESWL? Clear? First of all, absolute, and second is relative. Absolute and relative. Okay. So absolute contraindications we discussed. First, pregnancy. Why? Because there is increased risk of injury to fetus. And second, bleeding disorder. Why? Because of increased risk of hematoma. Okay. Now, what are the relative contraindications? First, there is increased risk of extrasystole. So if a patient is having pacemaker, that is also a relative contraindication. Clear? So cardiac pacemaker, there is increased risk of UTI. So if there is already UTI, that increases the risk. Distal obstruction, we discussed. Uncontrolled hypertension, obesity, orthopedic abnormalities. Orthopedic abnormalities. Okay, what kind of orthopedic abnormalities? Generally, see, if a patient is having scoliosis or kyphoscoliosis, in which spine is not straight, okay, so it's very difficult to focus the shock waves exactly to the kidney and the stone. So in these cases there is problem. So which orthopedic abnormalities? Scoliosis and kyphoscoliosis. Okay, renal failure and aneurysm. Clear? So these are the contraindications. Now one simple principle is there. See, most of the stones are being treated by ESWL, and if there is some contraindication, generally in those cases we are going to treat those stones by PCNL. Suppose size is up to 2 cm, we are going to treat it by ESWL, and if it's more than 2 cm, we go for PCNL. If there is UTI, if there is distal obstruction, we go for PCNL. So we are going to discuss PCNL, and the full form is percutaneous nephrolithotomy. Now see what's done in PCNL, percutaneous nephrolithotomy. You can see this is kidney. So this is kidney, okay, and this is the skin. So here you can see that this is the skin and this is the kidney. So the name is percutaneous nephrolithotomy. So percutaneously means via skin. I'm going to create a track with the help of needle, and I'm going into the kidney via calyx. So I create a track via a needle, and after that I dilate the track. Via that track I insert a scope, that's known as what? Nephroscope. And here you can see that this is nephroscope, in which there is eyepiece, there is a channel for irrigation, there is a channel for draining the irrigation fluid, and there is ultrasound probe. Clear? Now what we are going to do, we are going to create a track from the skin to the kidney. We are going inside the kidney, we are going to break the stone, and after breaking the stone, what we are removing? The fragment of stone. It means here distal obstruction is not a contraindication. Okay, so see, in detail we are going to discuss PCNL, percutaneous nephrolithotomy. Now see the blood supply of kidney. Suppose this is the kidney, this is the blood supply. It is supplied from renal artery. Renal artery, before supplying the kidney, is divided into anterior and posterior branch, and it is going to supply the kidney. Okay, for PCNL, which approach is preferred, anterior approach or posterior approach? So we are going to prefer the posterior approach, and in the posterior approach we have two approaches. Here you can see in this diagram that via calyx I entered the kidney, and sometimes via pelvis also you can enter the kidney. So if you are going for posterior pelvic approach, what's the problem? You are going to injure this artery. Which branch? Posterior branch of renal artery. So we have two approaches: posterior calycial approach, posterior pelvic approach. Which one is preferred? Posterior calycial approach, because in posterior pelvic approach there is increased risk of which artery? Posterior branch of renal artery. Clear? Okay, so in PCNL we are going for which approach? Is the posterior calycial approach. Why? To prevent the injury of posterior branch of renal artery. Okay, if you have seen any surgery of kidney, suppose you have seen the pyelolithotomy, open surgery, and if we are giving incision over the surface of kidney, what you have noticed, the kidney is highly vascular organ. The moment you are giving any kind of incision over the kidney, massive bleeding starts, right? So whenever you are creating this kind of track with the needle and inserting nephroscope, what is the complication? Bleeding. So the most common complication of PCNL is what? Bleeding. So here, what's the most common complication? Bleeding is the most common complication. Simple. After that, what are the organs which are injured in PCNL? Now see, posterior calycial approach is preferred, and whenever you are performing this posterior calycial approach, see 6th, 8th, 10th, 6th, 8th, 10th and 8th, 10th, 12th. These two numbers are in relation to which two organs? Lung and pleura. 6th, 8th, 10th related to lung, 8th, 10th, 12th related to pleura. So whenever you are performing PCNL, sometimes there is injury of pleura, and it's not known intraoperatively, sometimes it's missed. Second, you can injure colon, because colon is in close relation with kidney. And if you talk about spleen on left side, you must be knowing that there is a relation between left kidney and spleen. So the most commonly injured organ is pleura, followed by colon, followed by spleen. Okay, so if a question is asked, what is the most commonly injured organ? So the most commonly injured organ is pleura, followed by colon, followed by spleen. Simple. Now coming to the indications. Whatever the conditions in which ESWL was contraindicated or cannot be done, in all those cases we can use what? PCNL. So what was the size of stone which was removed by ESWL? 2 centimeter. So what are the indications of PCNL? Indications of PCNL. Okay, so first, size. Common sense question, how much? More than 2 centimeter. Second, distal obstruction. Third, UTI. Fourth, hard stones. I told you one mnemonic for hard stones, and the mnemonic was BHC2. So what's the full form of BHC2? It's the brushite, hydroxyapatite, cysteine, calcium oxalate monohydrate. Fifth, lower calycial stone. Okay, so whenever the stone is there in the lower calyx, you might break it with the help of ESWL, but since it's against gravity, it's very difficult to get the stone into ureter. So what happens if the stone is in the lower calyx? It's better to break the stone by PCNL and remove the stone directly under vision. Clear? And the sixth is staghorn calculi. Staghorn calculi. Clear? And for the staghorn calculi, what's the treatment? We go for sandwich technique. And what's that? It's the PCNL plus ESWL. So we go for sandwich technique, and that is PCNL plus ESWL. Now tell me, what is the name of this intervention? This is ureteroscopy. Okay, and how we perform ureteroscopy? First of all, we have to perform the cystoscopy. So you have to go inside the bladder and perform the visualization of bladder. Cystoscopy. After performing cystoscopy, you have to insert one scope into the ureter and you perform the visualization, that is ureteroscopy. Right? Now, what is the internal diameter of ureter? 4 mm. So here we are performing URS, that's also known as ureteroscopy. The internal diameter of ureter is 4 mm. It means what should be the diameter of ureteroscope used? Obviously less than 4 mm, means 3 mm. Now, whenever you are using this sharp instrument, the diameter 3 mm into the ureter, and you are not very gentle, what happens? Yes, in that case, if you are not very gentle, not very careful, this sharp instrument goes out of ureter. So what happens? Perforation. So the most common complication of URS, ureteroscopy, is perforation. That's why the surgeon has to be very careful. Second, this should not be performed under local anesthesia. Generally, this is performed under spinal anesthesia. Because if you're performing it under local anesthesia and patient is going to take any kind of turn, what happens? The ureter is injured. So first, important point, that it is performed under spinal anesthesia. Right? And what is the most common complication? It's the ureteric perforation. Despite of taking the precautions, ureteric perforation, this is the most common complication. Okay, simple. Now, what you can do with the help of this ureteroscope? Imagine you can visualize the ureter. If there is some kind of foreign body here, you can see there is a stone. So if there is a stone, with the help of Dormia basket, you can remove the stone. You can break the stone, then remove the stone. If there is foreign body, sometimes you have noticed that DJ stent is being inserted. DJ means double J. DJ means double J stent is inserted. Sometimes the fragments of DJ stents are there. So if some foreign body is there, you can remove that. If you have to insert DJ stent, you can insert the DJ stent with the help of what? Ureteroscopy. And sometimes there is urothelial tumor, we can take what? Biopsy. So these are the indications of URS or ureteroscopy. So what are the indications of ureteroscopy? So first, removal of ureteric stone, removal of ureteric stone, removal of foreign body, DJ stent insertion, DJ stent insertion, and taking biopsy from urothelial tumor, biopsy from urothelial tumor. Sometimes we use intracorporeal lithotripsy also for stone removal. So what is the difference between extracorporeal and intracorporeal lithotripsy? We discussed ESWL. In ESWL, shock wave was generated outside the body. But in intracorporeal lithotripsy, the stones are broken inside the body and then fragments are being taken out. Clear? So what are the types of intracorporeal lithotripsy and which types of lithotripters are used? Intracorporeal lithotripsy. First, what kind of lithotripters are used? Okay, so first is electrohydraulic lithotripter. Second, ultrasonic lithotripter. Third, ballistic lithotripter and laser lithotripter. Okay, these two are not used nowadays. First, electrohydraulic lithotripter. Okay, this electrohydraulic lithotripter is cheap and it's very effective. It's cheap and it's very effective, but it's not very safe. And since it's not very safe, we are generally not using this for kidney stone, but we are using this for bladder stone. So electrohydraulic lithotripter, it's cheap, very effective, but the problem, it's not safe. So we are restricting its use for bladder stone, used for bladder stone. Okay, now coming to laser lithotripter. This question is frequently asked in exam, that which kind of laser is most commonly used, and this is Hoyag laser. Hoyag. What is the full form of this? Hoyag laser. And this is holmium-Yag laser. This holmium-Yag laser is not only used for renal stones, it is also used for BPH. So this is used for both renal stones as well as BPH. How it acts? It acts by vaporization. So what it does, it is going to cause stone vaporization by photothermal mechanism. So it causes stone vaporization, and by which mechanism? By photothermal mechanism. Okay, so we have to be very careful that there should not be any metallic wire in the field, because that can also be affected. Second, especially if patient is having uric acid stone and you are using the holmium-Yag laser over the surface of uric stone, what happens? There is production of cyanide. This was the question asked in AIIMS. So if patient is having uric acid, because of use of laser, what's the problem? There is production of cyanide, but there is no significant toxicity. But there is no significant toxicity of this cyanide. So laser lithotripter is very effective, but what is the only problem with laser? It's very costly. So the problem of laser is high cost, and what's the advantage? It's very effective. It's very effective. Clear? So these are the various treatment options used for renal and ureteric stone. Okay, so in detail we are going to discuss how we are going to manage the renal stones and ureteric stones. First, have a look of renal stones. Management of renal stones. Okay, so first question, suppose the size of renal stone is up to 2 centimeter. Yes, what is the treatment of choice? It's ESWL. And if size of stone is more than 2 centimeters, so what is the treatment of choice? PCNL. More than 2 centimeter, it's PCNL. Third, if the patient is having heart stones, pneumonic BHC2, bruchite, hydroxyapatite, cysteine, calcium oxalate monohydrate. So for hard stones like BHC2, in that case also we go for what? PCNL. And if patient is having staghorn calculi, this question was asked in AIMS once, that there is staghorn calculi, which of the following is preferred treatment option? So you have to choose the combination of PCNL plus ESWL. But in that question, PCNL and ESWL combination was not there. PCNL, ESWL, URS were mentioned. So if you have to choose only one, you will choose which one? PCNL over ESWL. So fourth, if the patient is having staghorn calculi, so in staghorn calculi, we go for sandwich technique, and that is PCNL plus ESWL. So this is how we manage the renal stones. Now coming to the management of ureteric stones. See, in the ureteric stones, two things are going to decide the treatment option. One, first, what is the location? Where exactly the stone is located, and second, the size. So see, the management of ureteric stones. Management of ureteric stones. Clear? Now see the diagram. This is the kidney and this is the ureter. This is the bladder. This is upper 1/3, this is middle 1/3, this is lower 1/3. See, whenever the stone is there in upper 1/3 and middle 1/3, I can use ESWL. But if the stone is located in the lower 1/3, lower 1/3 of ureter is located in the pelvis and it's a bony cavity, so you cannot deliver the shock waves. Clear? So if the stone is located in upper 1/3 or middle 1/3 and the size of stone is up to 1 centimeter, what's the preferred approach? ESWL is preferred over URS. And whenever the size of stone is more than 1 centimeter, here the preferred approach is URS, right? And when the stone is located in lower 1/3, what is the preferred treatment option? URS. This question was asked many times. See one example. A patient who is having 9 mm stone in the lower 1/3 of ureter, what is the preferred treatment option? So we can remove it by URS, ureteroscopy. In ureteroscopy, you cannot only remove the stone, you can break the stone also. Clear? So you can break the stone into fragments and then you can remove the fragments. So this is how we manage kidney and ureteric stones. Now we are going to discuss infectious disorders of kidney. Okay, so before discussing infectious disorders of kidney, 4 terms and 4 conditions which are frequently asked in exams, let's discuss that. First is emphysematous cholecystitis. You must be knowing emphysema means relation of air or presence of air. So emphysematous cholecystitis, inflammation of gallbladder with presence of air. So it should be caused by some air producing organism. So what is the most common organism responsible for emphysematous cholecystitis? It is Clostridium perfringens or Clostridium welchii. And you know that Clostridium perfringens or welchii is an anaerobe. So question, what is the most common aerobic organism responsible for emphysematous cholecystitis? And that is E. coli. Now see the twist. Emphysematous pyelonephritis means involvement of kidney. So emphysematous pyelonephritis, what is the most common organism responsible? E. coli. Xanthogranulomatous pyelonephritis, in which there is xanthogranulomatous inflammation of kidney and it is caused by Proteus, most common organism Proteus, and which stone is associated? Yes, staghorn calculi. Fourth term is xanthogranulomatous cholecystitis, and this is a non-infectious condition. It is caused by rupture of Rokitansky of sinuses. Okay, so see the 4 conditions which are asked. First, emphysematous cholecystitis. Most common organism is the Clostridium perfringens or Welchi, followed by E. coli. Perfringens is an anaerobe, E. coli is an aerobe. Next is emphysematous pyelonephritis. And what is the most common organism? It is E. coli. Clear? Next is xanthogranulomatous pyelonephritis. And here the most common organism is Proteus, and it is associated with which stone? Struite or staghorn. And xanthogranulomatous cholecystitis. This is a non-infectious condition and it's caused by rupture of Rokitansky-Aschoff sinuses. So it is caused by rupture of Rokitansky-Aschoff sinuses. Clear? So in kidney, emphysematous pyelonephritis and xanthogranulomatous pyelonephritis is frequently asked. Now see, there is certain common points. Okay? There are certain common points between these two pyelonephritis because it's pyelonephritis. So whenever there is inflammation of kidney, what's the problem? There is local tenderness and pain, there is fever with chills and rigor. Since in both of these conditions, what's the problem? There is infection, so IV antibiotics should be given, and whatever the predisposing factors are there, like in emphysematous pyelonephritis, diabetes mellitus is one of the predisposing factor. So we have to control the blood sugar. In xanthogranulomatous pyelonephritis, what kind of stone is there? Staghorn. We discussed staghorn calculi are big. These are large stone and these are going to cause silent destruction of kidney. So there is hydronephrosis. So that's why the patients who are having xanthogranulomatous pyelonephritis, apart from fever with chills and rigor, what else is palpable? There is palpable mass in the flank. Clear? In both of these conditions, if a life-threatening situation is there, what we have to go for? Nephrectomy. Sometimes there is some pus collection. In that case, we have to drain that. Okay. So one by one, we are going to discuss first emphysematous pyelonephritis. So emphysematous pyelonephritis. So we discussed what's the problem here. There is presence of ring of air around the kidney or inside the kidney, and the most common organism is E. coli, and there is a sister of E. coli. Which one? Klebsiella. So it's followed by Klebsiella. Okay, UTI is more common in females, so this condition is more common in females, and this condition is more common in diabetics. Okay, what are the clinical features? So since pyelonephritis is there, so what's the problem? There is flank pain. Simultaneously, there is fever. There is vomiting. What's the problem? Patient is diabetic and it is associated with high risk of mortality. That's why early intervention is required in this condition. How much is the risk of mortality? 19 to 43%. So the mortality associated with this condition, 19 to 43%. Emphysema means presence of air. So on X-ray you can see the presence of air around the kidney. But which one is better investigation? CT. So how we are going to make the diagnosis? We can make the diagnosis by X-ray also. We can find the presence of air around the kidney. But what is the investigation of choice? And that is CT scan. So investigation of choice for diagnosis of emphysematous as well as xanthogranulomatous pyelonephritis, what? It is the CT scan. Now coming to the management. Okay, so first we have to resuscitate the patient, we have to give IV antibiotics, we have to control the blood sugar of patient. So what's done? Basic treatment options: resuscitation, IV antibiotics, control blood sugar. Okay, basic management options. After that, if there is evidence of pus collection, in that case, drainage of pus. Clear? and in certain conditions even nephrectomy is required to save the life of patients. Second, if patient condition is not going to improve, to save the life of patient we go for nephrectomy. Next is xanthogranulomatous pyelonephritis. So we discussed it is caused by which organism? It is caused by Proteus. Okay, and what kind of stone is there? Struite. And you know that this struite stone is large, causes silent destruction, so it leads to what? Hydronephrosis, and generally it leads to obstruction, so this obstruction leads to hydronephrosis. And because of this hydronephrosis, apart from fever with chills and rigor, abdominal pain, what is the other symptom? If you palpate, it leads to, so on palpation you are going to find what? Flank mass. Clear? Now the name is xanthogranulomatous inflammation. So generally in xanthogranulomatous inflammation there is presence of xanthoma cells. And what are these xanthoma cells? These are lipid laden histiocytes. So in this case there is presence, this is a question asked in pathology, there is presence of xanthoma cells. Okay, and these are foamy lipid laden histiocytes. So a question is asked that this xanthogranulomatous pyelonephritis mimics which condition? It mimics clear cell variant of RCC. So which variant? Clear cell variant of RCC. Clear? See, what are the clinical features we discussed? There is flank pain, there is fever with chills and rigor, and what else? Since there is hydronephrosis, chronically obstructed kidney, so you are going to find what? Flank mass also. So there is flank mass also. What is the investigation of choice for diagnosis? We go for CCT. So diagnosis, here investigation of choice for diagnosis, and that is CCT. Clear? What is the treatment option? See, the kidney is chronically obstructed hydronephrotic. So generally in these cases initially we go for partial nephrectomy, and if that is not adequate then we may have to go for total nephrectomy. So treatment, initially partial nephrectomy, and if this partial nephrectomy is not possible, if it's not possible then we can go for total nephrectomy, means we have to remove the whole kidney. So this is how we are going to manage xanthogranulomatous pyelonephritis. Now we are going to discuss pyonephrosis and perinephric abscess. So see the basic differences. What is pyonephrosis? Pyonephrosis means kidney is bag of pus. So the pus is collected inside the kidney, and perinephric abscess means the pus is collected around kidney. So this is perinephric abscess. Okay, so the basic difference, this is the kidney, right? And in pyonephrosis the pus is collected inside the kidney, right? So kidney is bag of pus. And see what happens in the perinephric abscess. This is the kidney, so here is the collection of pus. So pus is collected, the pus is collected around kidney, right? Now basic differences. So what happens in pyonephrosis? Generally in these patients kidney is obstructed, chronically obstructed, and because of this chronic obstruction what happens? There is hydronephrosis, and because of this hydronephrosis when it's infected there is pus collection inside the kidney. What is the problem in pyonephrosis? So over a long period of time, what's the problem? There is destruction of renal parenchyma also. So these patients have decreased erythropoietin also. So what is the problem? Since pus collection is there, so these patients will be having fever with chills and rigor. There is decreased erythropoietin because of destruction of renal parenchyma. So these patients will be having anemia. And because of hydronephrosis and pus collection inside the kidney, there is mass in the loin. But what happens in perinephric abscess? There is collection of pus around kidney. So the patients will be having pain, tenderness, fever with chills and rigor. But usually anemia is not seen and there is no mass in loin. Clear? So we will discuss in detail what happens in pyonephrosis. Here there is pus collection inside the kidney. It's inside the kidney. Okay, so what's the problem here? Kidney is bag of pus. It's the bag of pus. So you can feel the bag when you palpate. Okay, and what about perinephric abscess? Here the pus collection is around kidney. Pus collection around kidney. Okay, right? Now it is very easy to understand. See, in pyonephrosis we discussed that generally there is chronic obstruction. Okay, chronic obstruction. What is the cause of obstruction generally in kidney or ureter? Generally it's the stone. So because of stone there is chronic obstruction. Because of that there is hydronephrosis and there is infection. So what happens? There is pus collection. Clear? Now see the symptoms. What are the clinical features? This is very easy to understand. So because of pus collection, the patient is having what? Fever with chills and rigor. Because of this hydronephrosis and there is destruction of renal parenchyma. There is destruction of renal parenchyma. Because of that there is decreased erythropoietin. So what's the symptom? These patients have anemia. And what? Because of hydronephrosis and pus collection, what's the third problem? These patients have mass in loin. So there is palpable mass in loin. Clear? So these are the clinical features. So what are the clinical features? Fever, anemia and mass in loin. Clear? How we are going to make the diagnosis of pyonephrosis? So we are going to make the diagnosis on ultrasound. So generally it is diagnosed on ultrasound. Okay, now one basic thing I told you about pus collection in the body. Whenever there is any amount of pus collection anywhere in the body, usually what's the problem? Initially patients are having pain and tenderness at the local site. There is fever with chills and rigor. And how we are going to manage? If it is located superficially, okay, so then we go for incision and drainage. And if it is deep seated, means if it's in abdomen, then we prefer what? Ultrasound or CT guided percutaneous aspiration. And if that's not possible, then only we go for open drainage. Clear? So here also similar protocol is being followed, and for infection we have to give antibiotics, right? So what's the management? So in these patients we give what? IV antibiotics plus we go for drainage. Okay, 2-3 times this question was asked indirectly. Names. See the question. A diabetic patient who is having pyonephrosis and obstructed ureter presented to your emergency. At the time of presentation patient was unstable, right? After resuscitation, what is the next best step? So how we are going to drain? Yes, we are going to drain it by percutaneous nephrostomy, so that obstruction is also relieved and we are going to drain pus also. Clear? So we have a second option which is frequently asked in exam, percutaneous nephrostomy, especially in unstable patients. And which patients? The patients who are not immediately fit for surgery, like elderly and diabetic patients. Okay, so percutaneous nephrostomy. Why? To drain the pus, to drain the obstructed system, especially in elderly and diabetic patients. And whenever kidney is non-functioning or the function of kidney is less than 10% on DTPA scan, so for non-functioning kidney we go for nephrectomy. So this is how we manage pyonephrosis. Now have a look of perinephric abscess. Perinephric abscess. Okay, so what is the problem here? In this case the pus is collected around kidney. So here there is collection of pus around kidney, right? Now how this pus or infection reached here? There are two routes. One is cortical extension. So the patient is having UTI, there is extension of infection to kidney, and then there is cortical extension. So the root is, one is cortical extension, clear, and the second is hematogenous spread. Okay, so there is hematogenous spread. Okay, one simple question: what is the most common organism responsible for UTI or most of the infections of genitourinary tract? That's E. coli. So the same organism is responsible for perinephric abscess. So the most common organism responsible, okay, and that is E. coli. Simple. Now see the problem. Here, pus is collected around the kidney, so patient will be having pain, patient will be having tenderness, fever with chills and rigor. But hydronephrosis component is usually not there. There is no pus inside the kidney, so what, mass is not felt, and there is no significant destruction of renal parenchyma. So what, erythropoietin is not decreased, so patient is not having anemia. Clear? So this is how you can differentiate it from pyonephrosis. So clinical features: there is pain, there is tenderness, there is fever with chills and rigor. Okay, right? Now how we are going to make the diagnosis? Diagnosis can be made by ultrasound or CT. So diagnosis, we can diagnose it by ultrasound or CT. Okay, and the management protocol is very similar. We have to give IV antibiotics, and generally what we prefer, percutaneous aspiration or percutaneous drainage. So management, we give IV antibiotics plus percutaneous drainage. Now imagine if the patient is not responding after percutaneous drainage, then we have to attempt what, open drainage, or if the function of kidney is less than 10%, then the second option is what, nephrectomy. So if patient is not responding, so we have two options: either we go for open drainage, or the function of kidney is compromised. In that case, we can go for nephrectomy. Clear? Nephrectomy. So this is how we are going to manage perinephric abscess. Now we are going to discuss hydronephrosis. Okay, so what is hydronephrosis? This is aseptic dilatation of kidney. Okay, aseptic dilatation of kidney. Now generally what is the cause of hydronephrosis? It is caused by obstruction in the urinary tract. It can be unilateral or bilateral. So there are certain basic concepts which you have to remember. See, this is kidney, this is ureter, this is bladder, this is prostate, this is urethra. Okay, now anywhere in this genitourinary tract, especially the urinary tract, anywhere in the urinary tract, if there is obstruction, patient is having His. What is His? The full form of His. Anywhere in the urinary tract, if the patient is having obstruction, there is His. His means, S means stone, I means infection, and H means hydronephrosis, which is aseptic dilatation. Now, depending upon the site of obstruction, patient might be having hydronephrosis, hydroureteronephrosis, unilateral hydroureteronephrosis, or bilateral hydroureteronephrosis. Okay, it's very easy to understand. See, whenever the obstruction is here, right, in the ureter, just after pelvis or at PUJ, so in this patient there will be hydronephrosis. Whenever obstruction is here, this patient will be having hydroureteronephrosis. What kind of? Unilateral. And whenever the obstruction is distal to bladder neck, imagine here, or distal to the bladder neck, like in cases of BPH, in cases of urethral stricture, what will happen? Patient will be having bilateral hydroureteronephrosis. Simple. One principle is clear. Second, the obstruction can be, the etiology can be outside the ureter. So this is what, outside the wall of ureter. Extramural. It can be inside the wall. Outside wall means some malignancy. Inside the wall means some kind of stricture in the ureter. So this is intramural, and sometimes in the lumen That's intraluminal. And what is the most common cause of intraluminal obstruction? Stone. Clear? So see, what are the etiologies of unilateral hydronephrosis and bilateral hydronephrosis? So first we are going to discuss unilateral hydronephrosis. Unilateral hydronephrosis. Okay. Now see the etiology. It can be extramural, means just extramural means outside the wall. It can be intramural, means in the wall of ureter, and it can be intraluminal, means within the lumen there is obstruction. Okay, so generally these extramural causes are because of advanced malignancies. These are because of advanced malignancies. Okay, so what are those advanced malignancies which can compress the ureter? Obviously colorectal cancer. See the relation of ureter in the pelvis. And what else? Carcinoma prostate, and in females carcinoma cervix. So colorectal cancer, carcinoma prostate, and carcinoma cervix. Clear? Other causes, we discussed retroperitoneal fibrosis in peritoneum. So there is fibrosis, retroperitoneal fibrosis. It is going to compress the ureter. Retroperitoneal fibrosis. And what else? Retrocaval ureter. Retrocaval ureter. What happens in retrocaval ureter? Ureter goes behind IVC, takes U-turn before draining into the bladder. So all these are extramural causes. Now coming to intramural causes. First, in children, this is common, PUJ obstruction. There can be uretrocele, then ureteric stricture. Okay, and there is a tumor arising from ureter or some urinary tract. That is what? Urothelial tumor. So that is urothelial tumor. Clear? And what is the most common cause of intraluminal obstruction? Obviously, there is stone. There is stone. Sometimes there is papillary slough inside the lumen. And what are the causes of papillary slough? There are many causes, but which are asked in exam. One is analgesic nephropathy and sickle cell anemia. So there is presence of papillary slough. Clear? And what are the causes? Analgesic nephropathy, and sickle cell anemia. Clear? And what else? There is ureteric stricture. So that can also ureteric stricture. Clear? So this can also lead to intraluminal obstruction. So all these are the causes of unilateral hydronephrosis. And we discussed for bilateral hydronephrosis, the obstruction should be beyond bladder neck. So see, bilateral hydronephrosis. Okay, so the causes are divided into congenital and acquired. So what are the congenital causes and what are the acquired causes? Clear? So congenital causes: posterior urethral valve, it should be beyond the bladder neck, and urethral atresia. This is also seen in children, urethral atresia. So these are congenital causes. What are the acquired causes? So see, bladder neck stenosis is the bladder neck stenosis. Clear? Second, BPH, carcinoma prostate, okay, and urethral stricture. Clear? So these are the causes responsible for bilateral hydronephrosis. Now coming to the clinical features. See, the clinical features are a bit different in unilateral and bilateral hydronephrosis. Now see why. In unilateral hydronephrosis, in majority of cases, what is the cause? It's the intraluminal obstruction. What is the cause? It's the stone. So whenever there is stone, there are two kinds of symptoms. One, whenever the stone is going to obstruct the kidney, means when it's obstructed the pelvis, what's going to happen? There is stretching of renal capsule, and because of that, what happens? There is non-colicky pain. And sometimes when this stone goes inside the ureter, so there is hyperperistalsis of ureter, and this leads to what? Colicky pain. So patient might be having dull aching pain, or patient might be having colicky pain. Patient can present with acute ureteric colic. So see the clinical features in unilateral hydronephrosis. Okay, so in these patients there might be dull aching pain, generally non-colicky, or this patient can present to you with acute ureteric colic. Acute ureteric colic. Okay, one term which is frequently asked in exam, and the term is Dietl's crisis. The term is Dietl's crisis, right? So what is this Dietl's crisis? This is known as intermittent hydronephrosis. Now see the problem. This patient complains of pain in the flank and palpable swelling. But what is the problem? This patient is going to pass huge volume of urine, and after passing huge volume of urine, what? The pain and the swelling subsides. So this is intermittent hydronephrosis. So in exams, Dietl's crisis is asked frequently. What is Dietl's crisis? The other name of Dietl's crisis, it's intermittent hydronephrosis. Clear? Now what is the problem in this patient? This patient is having flank pain and palpable swelling, and when the patient is going to pass huge volume of urine, generally the pain and swelling subsides. So this is Dietl's crisis. So in this case, there is severe pain in flank, severe pain, and there is palpable swelling. Clear? In flank. Okay, and it disappears after passage of large volume of urine. So patient passes large volume and it disappears. So it disappears after passage of large volume of urine. Right? Generally in unilateral hydronephrosis, since the other kidney is functioning, these patients are generally not having signs and symptoms of renal failure. Okay, but what happens in bilateral hydronephrosis? Generally the obstruction is beyond bladder neck, and since both kidneys are involved, so what happens? These patients might be having signs and symptoms of renal failure in advanced cases. And apart from that, since the obstruction is distal to bladder neck, so the patients are having signs and symptoms of bladder outlet obstruction. So what happens in bilateral hydronephrosis? These patients have signs and symptoms of bladder outlet obstruction, and in advanced cases, signs and symptoms of renal failure. Renal failure. Okay, now coming to the investigations, we discussed what is the screening investigation for hydronephrosis. It is ultrasound, and we go for IVP also, because IVP will tell you the site of obstruction, hydronephrosis, and it will give you rough idea about the renal function. But the investigation of choice is DTPA scan. Why? Because it will tell you exactly how much function is there in the kidney, right? So how we are going to investigate? Diagnosis. For screening, we go for ultrasound, we go for IVP, but investigation of choice for diagnosis, it's the DTPA scan, and we discussed what's the full form of DTPA scan. It's diethylene triamine pentaacetic acid scan. Now coming to the management. See, here the management depends on the etiology, that what's the underlying etiology. And if in any patient the function of kidney is less than 10% or it's non-functioning kidney, in that case we have to go for nephrectomy. Okay, so the management here, treatment depends on underlying cause. It depends on underlying cause, right? And whenever the patient is having non-functioning kidney, in those cases we go for nephrectomy. Clear? So this is how we manage the patients of hydronephrosis. In surgery, GI-TB and GU-TB are very important. GI means gastrointestinal tuberculosis and GU-TB means genitourinary tuberculosis. It's very, very important. We discussed GI-TB, now we are going to discuss GU-TB. Similarity. In both GI-TB and GU-TB, the most common organism is what? Mycobacterium tuberculosis. Clear? So, genitourinary tuberculosis. Right? So, first important point, what's the most common organism? So, obviously, it's the Mycobacterium tuberculosis. Simple. Generally, it is more common in males. And what's the age group? Age group is 20 to 40 years. Simple. Now, what is the first organ affected in genitourinary tuberculosis? Obviously, the first organ affected is lungs. From lungs, how the infection reaches to the genitourinary tract? It's by hematogenous spread. Clear? So, what's the first organ affected? The first organ affected is lungs. And from lungs, genitourinary tract is involved. By which spread? It's the hematogenous spread. Hematogenous spread. Okay. Now see how this infection reaches the genitourinary tract. You can see this is kidney, this is ureter, this is bladder, this is prostate, this is urethra, and this is vas deferens. Clear? So from lungs via hematogenous spread, two organs are affected primarily. Via hematogenous spread, which two organs are affected? Kidney and prostate. So by hematogenous spread, kidney and prostate are affected. Kidney and prostate. Simple. Rest organs are involved by either descent of infection or ascent of infection. What is the meaning? See, when the kidney is involved via urine, can you see the organism reaches ureter and then bladder? So this is known as what? Descent of infection. And when prostate is involved, what happens? Via prostatic urethra, this infection might reach what? The vas deferens. So this is what? Ascent of infection. So rest of the organs are involved by either descent of infection or by ascent of infection. Clear? In this diagram, you can see that one organ is missing and that organ is spared. So which organ is missing in this diagram? You can see what? Testis. So this testis is spared. So in genitourinary tuberculosis, important point, this testis is spared. Now see what is the pathophysiology of this genitourinary tract tuberculosis. So after hematogenous spread, what this bacteria is lodged into periglomerular capillaries. Periglomerular capillaries means around glomeruli. Bacteria is lodged. What is the good thing? That most of us are having good immunity. So because of that, this infection is either cleared or infection is dormant in the periglomerular capillaries or around periglomerular capillaries. When someone immunity goes down and when the immunity is compromised, what? There is activation of bacteria. So bacteria is lodged in periglomerular capillaries. Clear? And when immunity is down or patient is immunocompromised, in that case there is activation of bacteria. When there is activation of bacteria, this bacteria means Mycobacterium tuberculosis, it is going to cause what? Cortical granuloma. So there is formation of granuloma in the cortex. After that, there is formation of what? Tubercular abscess. So there is formation of this tubercular abscess, and this tubercular abscess ruptures into pelvic calyceal system. So when it ruptures into pelvic calyceal system, now pus enters into pelvic calyceal system and via urine it starts coming out. When pus mixes with urine coming out, patient is having what? Urinary frequency. So earliest most common symptom is increased frequency, and when this patient is having increased urinary frequency, which is the earliest most common symptom, patient is coming to us and we are sending the patient's urine for examination because I suspect UTI. So whenever I send patient's urine for routine and microscopic examination, what I find pus. And if I send the urine for urine culture sensitivity, since it's Mycobacterium tuberculosis, there is no growth within 48 hours. So what happens? It is sterile. Clear? So what is the problem? On culture sensitivity, there is no growth within 48 hours and there is pus collection on urine RM. There is presence of pus cells. So this is known as what? Sterile pyuria. Sterile pyuria. Clear? So this is just the beginning. So patient earliest most common symptom of genitourinary tract tuberculosis is increased urinary frequency and the patient is having sterile pyuria. This is the beginning. Now system wise, see what are the changes which are going to occur. First we are going to discuss what are the changes in kidney and ureter. So see the changes in kidney and ureter. Okay, so what happens? There is calicial stenosis or sometimes there is stenosis at PUJ. So in these patients there is calicial stenosis or there is stenosis at PUJ, and because of this stenosis there is obstruction. So the patient will be having what? Hydronephrosis, and because of this hydronephrosis what happens? There is pyonephrosis. But actually speaking, in the beginning, rather than pyonephrosis, there is collection of cheesy material. Clear? So what's that? That is caseous necrosis. So in these patients, there is caseous necrosis. Right? So in these patients, because of caseous necrosis, kidney is filled with cheesy material and that is known as putty kidney. So what? Here, kidney, it's filled with cheesy material. And this question was asked in JIPMER. It was an image-based question. So how it looks like? So see here, kidney is filled with cheesy material. When we do the grossing, you can see that whenever we do the grossing, we can see there is presence of what? This cheesy material. Over a period of time, what happens? There is calcification. And the calcified kidney is known as cement kidney. So kidney is filled with cheesy material. And what's the name of this kidney? This is known as putty kidney. In this there is scattered calcification also. Clear? After that, kidney is calcified, and this calcified kidney, see first how it looks like. So this is the calcified kidney, and this calcified kidney is known as what? This is cement kidney. This is known as cement kidney. And after that what happens? The kidney is non-functioning. That's calcification in the kidney, and the kidney is non-functioning. So non-functioning. So there is non-functioning calcified kidney. Clear? And this process is known as what? Autonephrectomy. So autonephrectomy is seen in genitourinary tuberculosis, and in medicine one question is asked, autosplenectomy is seen in sickle cell anemia. So autonephrectomy seen in genitourinary tuberculosis, autosplenectomy it is seen in sickle cell anemia. Now see what are the changes seen in bladder. Okay, so whenever this infection comes into the bladder, what's the problem? If we perform cystoscopy, what is the earliest change seen on cystoscopy? It's the pallor around ureteric orifice. So this is the bladder. Clear? This is the ureteric orifice. So this question is frequently asked. What is the earliest change seen in genitourinary tract tuberculosis on cystoscopy? So here it's the pallor. What's that? It's the pallor around ureteric orifice. After that, what are the sequence of events? See, in the bladder there is formation of tubercles. So here you can see there is presence of tubercles in this bladder. Because of these tubercles there is chronic inflammation, and because of this chronic inflammation there is fibrosis, and because of this fibrosis what happens? Contraction. So what are the sequence of events? There is chronic inflammation. Clear? Because of this chronic inflammation there is fibrosis, and because of this fibrosis there is contraction. So what will happen to the bladder? Bladder is contracted, and that is small contracted bladder, and this small contracted bladder is known as what? Thimble bladder. So what will happen? You can see the capacity of bladder. This is the capacity of bladder. So what happens? There is fibrosis. Clear? So there is small contracted bladder. So this is known as what? Thimble bladder. Clear? How it looks like? So here you can see this is small contracted bladder. So the capacity is decreased and it is irregular. It is looking like this thimble. So it's known as thimble bladder. Now what will happen to the ureteric orifice? Since the bladder is small and contracted, you can see the ureteric orifice will appear something like this. So you can see this is the appearance. So this is how this ureteric orifice appears on cystoscopy, and it is looking like what? Golf hole. So that's why this appearance is golf hole ureteric orifice. Question is asked that what is the earliest change seen on cystoscopy, and that's what? It's the pallor. But the students are doing this mistake in exam. They mark what? Golf hole ureteric orifice. Golf hole ureteric orifice, this kind of appearance is seen only in advanced cases. So you have to read the question, language of question carefully. So what is this? This appearance is golf hole ureteric orifice. Clear? And it is seen only in advanced cases. Now see what's the change in prostate. Okay, so prostate is calcified, and since the prostate is calcified it becomes hard and nodular. So there is calcification in prostate, and because of that it's hard and it's nodular. Simple. Now what is the change in vas deferens? Now what is the change in vas deferens? Vas deferens is having this kind of appearance. Okay, so tell me what is the name of this appearance? This is beaded appearance. So this is beaded appearance of vas. Okay, and this is the testis, this is the scrotum. Now what is the problem? In vas deferens there is stricture dilatation. Why? Because there is collection of pus, and what happens? It is going to rupture outside via scrotum. So when it is going to rupture outside via scrotum, there are multiple discharging sinuses. So what? Beaded appearance of vas with multiple discharging sinuses via scrotum is the characteristic feature of genitourinary tuberculosis. So this is beaded appearance of vas with multiple discharging sinuses. Okay, and we discussed what? The testis is spared. So these are the changes which are seen in genitourinary tract. Now how we proceed for the investigations? We start the investigation from urine. So we discussed that on urine RM, what's the finding? We go for urine RM, and there we find pus cells. We go for urine culture sensitivity, and on urine culture sensitivity it's sterile. There is no growth within 48 hours. So since it is sterile, this is what? Sterile pyuria. This is sterile pyuria. Okay. Question is asked that what is the investigation of choice for renal tuberculosis? So generally in the retroperitoneal pathologies we discussed that the investigation of choice is CCT. So for renal tuberculosis, investigation of choice for diagnosis is CCT. Now see the twist in the question. Investigation of choice for early changes. Investigation of choice to detect early changes in the renal tuberculosis. And in the renal tuberculosis, early changes are confined to the calyx. And if you want to visualize the calyx, what is the better investigation? It is IVP. In IVP, which films are most informative? Early films or late films? So obviously early films, right? So three important questions. Investigation of choice for diagnosis of renal tuberculosis, right? And that is CCT. Okay. Now see, investigation of choice for diagnosis of early changes. You have to highlight this: early changes in renal tuberculosis. And if it's early changes, the investigation of choice is what? IVP. Which films of IVP are most informative? Early films. So early films of IVP are most informative. And what's the earliest change detected in IVP? So what is the earliest change detected in IVP? You can see. So this is what? Moth-eaten calyx. Here you can see the normal calyx. Here it looks like that it's eaten by a moth. So earliest change. This is sometimes image-based question also asked. This is image-based question asked sometimes. This is moth-eaten calyx. And there is another question, pipe stem ureter. We discussed in retroperitoneal fibrosis, there is pipe stem ureter. So whenever there is fibrosis, there is medial deviation of ureter, pipe stem ureter. This pipe stem ureter is also seen in tuberculosis. So on which investigation? If we perform retrograde pilogram, RGP, there is pipe stem ureter. Pipe stem ureter. So diagnosis is done. How we are going to manage tuberculosis? Obviously we have to give ATT. Apart from giving ATT, we have to manage the complications, right? So see the management. We go for ATT and plus we manage the complications. So management of complications. Okay, what are the complications? So in ureter there is formation of stricture or development of stricture, and if there is stricture, we have to go for stricture dilatation. In certain patients, the kidney becomes non-functioning if there is autonephrectomy. In that case, what we have to go for? Nephrectomy. Third problem, the patients are having small contracted bladder, that is also known as thimble bladder. And if the bladder is small and contracted, we have to increase its capacity. And if you have to increase its capacity, it is known as augmentation. How you are going to increase the capacity? With the help of bowel mucosa. So if we are using small bowel, so this is known as enterocystoplasty. So the term is augmentation enterocystoplasty. Okay, so the patient who are having ureteric strictures, if the patient is having ureteric stricture, we go for what? Dilatation. If the patient is having non-functioning kidney, in that case we go for nephrectomy. And if the patient is having small contracted bladder, small contracted bladder, in that case we go for enterocystoplasty. Enterocystoplasty, what kind of? It's the augmentation enterocystoplasty. There are certain situations, especially in the lower third of ureter, when the stricture is non-dilatable. In that case, what should be done? So imagine this situation. What's the problem? Here is the stricture in the lower third of ureter, and generally it's non-dilatable. If it's non-dilatable stricture, in that case what we are going to do? Can you see? We are going to remove that part of ureter. So this part of ureter is excised, and after excising this part of ureter, what I'm going to do? I'm going to raise a flap from the bladder. So I'm going to raise a flap from bladder, and after raising a flap from bladder, here you can see that I'm going to tubularize that bladder flap. I tubularize the bladder flap, and whatever the defect is there in the bladder, that is sutured. So here you can see the defect is sutured and it is tubularized. So I created a new ureter from the bladder flap, and this is attached to the rest of the ureter. So this is what formation of a new ureter. What's the name of this operation? This is known as Bouary's operation. And what's the name of this flap? This is known as Bouary's flap. Clear? So when there is non-dilatable stricture, especially in the lower third, or sometimes there is injury to lower third of ureter, and sometimes there is accidental ligation of lower third of ureter, in all those cases we go for this operation, and this is known as what? Bouary's operation. Clear? So this operation is for which part of ureter? This is done for distal third of ureter. So this is how we manage the complications of genitourinary tuberculosis.